Today, we're going to be asking the question to treat or not to treat, a discussion about early intervention for myelofibrosis. We're going to be hearing from Dr. Abdulraheem Yacoub. This topic was chosen because most studies on myelofibrosis are focused on high-risk patients with advanced and aggressive disease, but many patients don't fall into this category. So we're really going to be trying to figure out what the benefits are of early intervention for myelofibrosis today. And our speaker for this event is Dr. Abdulraheem Yacoub. Dr. Yacoub is a professor of hematologic malignancies and cellular therapies at the University of Kansas School of Medicine. Dr. Yacoub earned his medical degree from Jordan University in Amman, Jordan, in 2003 before completing a Heme-Onc fellowship at the University of Arkansas. Dr. Yacoub is internationally recognized for his work in myeloproliferative neoplasms such as myelofibrosis, and his clinic at the University of Kansas is recognized as both a key member of the NIH-funded consortium dedicated to research on MPNs, as well as an MPN Center of Excellence. Dr. Yacoub has been honored through numerous awards and invitations to speak throughout his career. He also serves as the lead global investigator and global lead for the LIMBER clinical trials, which aim to find the most effective upfront therapy in myelofibrosis. With that, I'm going to turn it over to you, Dr. Yacoub.
Thank you very much, Dalton, for this kind introduction and for creating this platform for us and patients to be able to interact and have constructive information exchange, both for me to learn about some of the patients' burning issues and needs, and also for patients to have a safe space to ask questions and learn more about their individual health. I'm going to try to share my screen. If Dalton, if you can give me permission for that, to try to kind of provide some uh, background information. But our topic today will be in regard to myelofibrosis and early intervention. But I'm going to start by broadening the topic a little bit, give some background about our diseases and how they're very much connected to each other. So myelofibrosis is a member of myeloproliferative neoplasms. This is a family of cancers, the blood, that behave in a certain predictable way, and they tend to evolve over the patient's journey with them. Those cancers are characterized by oftentimes a long life expectancy. However, a quality of life that is compromised um, because of the symptoms of the disease, and often patients end up with disease progression into a more aggressive form of the disease that occasionally can be the reason for the lives to end. And without effective therapy, we do not really wish for cancers to run their course, and we hope to allow medical professionals to provide interventions that can change the disease's course. So that being said, this is a group of cancers that are blood cancers. They stem from the blood myeloid elements, which is the mother cell that makes all our red cells, all our platelets, and most of our white cells. So this is a disease that affects the mother cells that makes all our blood elements. And expectedly, when you have a disease in those cells, all blood elements will be affected, maybe at different rates, but most patients with MPNs will have a different spectrum, maybe a unique spectrum per patient for how much their blood is affected with this disease. The way we make a diagnosis is by going to where the bone marrow lives, which is inside the bone. So basically, the bone is shaped like a sponge from the middle, and all these empty spaces are filled with the liquid organ that is the bone marrow. And for us to get a diagnosis, we have to do a bone marrow biopsy, which is inserting a needle into that bone marrow space to get an adequate sample that represents the disease. And we run all the ancillary and special testing on that guides our decision and our diagnosis and how we treat patients. So myeloid diseases as a family of cancers are not well known, but MPNs are one of those members of this big family that includes other more common or more well-known syndromes like acute myeloid leukemia. So MPN includes 3 or 4 unique syndromes. One of them is myelofibrosis. Um, so the other members are polycythemia vera and essential thrombocythemia. So these are basically a spectrum of the disease where essential thrombocythemia is an MPN with predominantly producing platelets. Polycythemia vera is an MPN with predominantly producing red cells, but it also can make a lot of platelets and a lot of white cells. And myelofibrosis is also an MPN that is characterized by uncontrolled production of platelets, red cells, and white cells, and also the deposition of scar tissue in the bone marrow. So a lot of those diseases are sometimes hard to tell among each other at presentation or during their disease course. Um, when um, one challenge in making a specific diagnosis is that there is an overlap. There are patients who have features that match between ET and myelofibrosis. We call that maybe early myelofibrosis or prefibrotic myelofibrosis. Some patients have features that overlap with polycythemia vera and so forth. And the other explanation is that patients actually change. Diseases do evolve as patients live with them. And you could start with a well defined, clear syndrome that is ET, and then with time, patients can change into a different phenotype or presentation like polycythemia vera or myelofibrosis. So diseases changing form is actually not even unexpected when patients live with their diseases for decades at a time. So we really have to be open-minded about this dynamic nature of these diseases and that they tend to get worse with time and they can change shape with time. So myelofibrosis has had the most attention among all the family of myeloproliferative neoplasms because it is the most severe form of the disease. And those are the patients who have compromised quality of life and duration of life because of their cancer. So those patients end up having a life expectancy on average that is shortened, sometimes shortened significantly. So patients with myelofibrosis were the ones who had the most clinical trials and investigations and research to try to define how we can improve on that. And even in myelofibrosis, patients with the most severe myelofibrosis were the beneficiaries of all the medical advancements that we've had. Nearly every drug that is approved for high risk, advanced, late phase myelofibrosis. And we are using it just off label or by extrapolation in other forms of the disease. It made sense to study drugs first in the higher risk disease because those are patients with the highest needs. They are the most at risk from their disease, and they also probably have the biggest disease burdens by having the most symptoms, the biggest spleens, and the most abnormal blood counts. So those patients would actually be it's more easy to measure their improvement. So that's really how we started developing drugs, and every drug we have approved for myelofibrosis has actually been studied and approved for high risk. We live in a world where very few options for patients who are truly low risk disease. Now, there is a difficult part or non-scientific part, and when we extrapolate the science, we apply in patients with high-risk disease, and then you take the same concepts and you try to apply them for patients who have different diseases or milder diseases. We don't understand those diseases as well. Those patients are they are going to do better. They are going to have different goals what they want for their care. They will live longer with their diseases. They don't necessarily accept the risk of drugs that are okay that can cause harm or toxicity. So those patients should be dealt with differently, and we start by understanding what is the wishes and the goals for these patients, and by designing clinical trials or interventions that help them in a way that actually improves what those patients think is the priority. So it really is a different process, different conversation to be had. These patients try to find how we can improve on health. So one tool we use to decide which patient is high risk and which patient is low risk is our risk assessment algorithms. So there are many of those. The most sophisticated is the one on the right, the molecularly inspired National Prognostic Scoring System. Now it's in the second version. So this calculator takes in clinical features, patient symptoms, patient's DNA or the disease's DNA, the mutations, and scrambles that into a calculator to predict which patients are low risk, which patients are high risk, and all therapies have been directed to the patients with the higher risk because they're at immediate risk of morbidity and mortality even. But we cannot tend to ignore the patients who are going to be doing well. So if you look at these curves are generated by the scores from these models. And let's say on the right side, if you're in the blue line, the yellow line, these are patients with high risk disease who have shortened life expectancy. They need immediate attention. While when you look at the patients on the burgundy or gray curve, or even the dark blue curve on the right, those are patients who, on a superficial look that they're doing better. So maybe they're less urgent to receive therapy. And that is really the misconception we're trying to discuss, is that maybe those are the patients who have a window of opportunity where we can help them more. And then, as we are very reliable on these tools are not always concordant. So sometimes you apply this tool and this patient is assigned as low risk. Then you apply a different tool, and then patients are high risk. So these tools are not perfect. They're only useful to provide guidance, maybe to synchronize the way we think of patients. But really, when it comes to an individual patient, it is really hard to use this as the only guidance of how patients will behave and who is actually low risk and who's actually high risk. So, as doctors, we're still not as good at determining who's the highest risk of all and who's the lowest risk of all. And we're really a lot more unsure when it comes to specifically to the lower risk patients, because lower risk patients are not all in the same box. Some of them are truly low risk who live with MF for decades and they grow older and they have their full natural life. And some of them are low risk, but they quickly progress into high risk. So we're really not as accurate when it comes to that. Something else that we can improve on is by having good assessment of how the disease affects patients' quality of life. So we think that patients who have relatively lower risk cancers are probably going to do better in all aspects, but that's not true, because even patients with low risk disease can be very symptomatic, and their symptoms can be a significant burden to their quality of life, even more so than patients with high risk disease. As you can see on this graph, their patients have myelofibrosis, polycythemia vera, or ET, which is the lowest risk of all diseases. All these patients have significant symptoms that they suffer with every day, and they affect their quality of life every day. So those patients are not completely happy or healthy or unbothered by their diagnosis. They actually have needs that need to be met, and we just do not have tools yet approved for these patients. So it's definitely an unmet need and room for improvement, a big opportunity to help these patients. And then when we have a discussion between doctors and patients, and what do doctors want for their patients and what do patients want them for themselves, that is not always identical. They don't always meet eye to eye. So, for example, most doctors answer that they want their patients to have less symptoms and better quality of life, period. On the other hand, if you ask patients, they also want that, but also they are willing to take some therapy that could promise them a better future, even if there is initial side effects or risk. So basically, an investment in their own health. So they're willing to accept some interventions that might be changing or delaying their disease course, basically modifying their future. That is the biggest answer we get from patients. Is that yes, I will take a therapy that will give me a better future, even if it has some side effects now. Basically, a trade for a better future. doctors are still not meeting eye to eye with patients on this, but really this is what is a strong argument, is that this is patient driven, is that patients are asking for this and announcing this as a priority, is that I want a better future, even if I have to do more work now. So, in if I was going to design the best, most optimum therapy that would offer patients with low risk, it really would be a therapy that can truly impact the disease, eliminate the disease, cure the disease by measurements of improving patients' outcomes, by living longer and living better lives, and that this therapy um, we can tell early that it's working, so that for some patients, no therapy will work for everybody. For some patients where it's working, you want to continue it. Patients where it's not really helping them, you want to stop early, to de-escalate. And we want those therapies to be sustainable, financially sound, and can be expanded to the patients at large, and maybe even targeted. Maybe patients with certain mutations get different therapy than patients with other mutations. Really, we're still in search for the best tool to apply patients to achieve early intervention. And even the word early intervention is controversial. So, what is early? Is it early meaning the minute you're diagnosed, you get therapy? Or is it early means you get therapy at the lowest disease risk, not the highest disease risk? Or is it early where you interfere when you don't even have myelofibrosis, right? And there's diseases that lead to myelofibrosis, like ET and PV and people like myelofibrosis. Can you interfere even that early? So all these are definitions of what could be early intervention. There's the exact opposite definition, which is you interfere with very aggressive therapy immediately for these patients so that you provide the maximum therapy early on, and maybe you can de-escalate down the road. So early intervention could be actually escalation of care, providing more aggressive combinations of drugs, provide the maximum benefit early so that patients can have sustained and longer benefit. So really all of these are possible definitions, and maybe all of them are appropriate definition of what an early intervention could be. We've seen results in which we have done interventions in patients and patients live longer. One of them is ruxolitinib or Jakafi. So for patients with ruxolitinib, the very first study, although it was for patients with high-risk disease, but it was a randomized study, meaning half the patients got therapy, half the patients got placebo, and then the placebo patients were allowed to cross over maybe 9 months later. But even though they crossed over, they never caught up with the patients who got therapy early, meaning this therapy delay for 9 months was detrimental. Patients lived a year and a half shorter because they got therapy 9 months later. So obviously, this is solid evidence that the early intervention actually did so well that late intervention could not make up for that loss, and that patients who were treated relatively earlier or at lower risk did even better than patients treated later on in their course or at higher risk disease. And that was reproduced by many other studies. There's actually a lot of studies with prospective evidence showing that treating patients with the same drug earlier on in their disease will result in significant benefit downstream. So we're really sold on the fact that early intervention is more effective. We also have evidence that early intervention is more gentle. So patients who got therapy early in their disease actually continue to have better hemoglobin, better platelets, less side effects to therapy. They stayed in therapy longer. So really applying the therapy early was also gentler to patients than waiting until they're more advanced and then using the same therapy. And then all of that ended in improving patients' outcomes. So patients live longer if we apply these concepts of early intervention with Jakafi. That's the only intervention. So based on that, we designed many studies in which we apply early just with doublets, so Jakafi and a combo. There's been many studies designed for this. These are the three biggest global studies that were studied in trying to advance combination of drugs early on. So far, 2 studies on this slide were negative, and the only study that is still not negative but not positive is the one on the bottom left. We're still waiting, maybe potentially in the future, we'll be offering patients 2 drugs instead of one early on so that they can get the maximum benefit early on and enjoy that benefit for much longer. Now, another option is to interfere with therapy, and this is something I preach on all the time, which is you to provide patients with lower risk MF or lower risk diseases like ET and MPN. If you provide therapy with interferon, you can actually um, result in changing the disease course, and that could actually prevent the patient's bad outcomes 10 or 20 years down the road. So that there is actually evidence for this. So this has been done before in this institution in New York, in which patients who got interferon versus other therapy, 30 years later, more interferon patients were alive and not progressed to MF than patients who got other therapy. So obviously, with long-term therapy, there was patients did better and lived longer with more successful biological therapy like interferon. We have done this in our own trials with interferon, treating patients early or treating them late. Patients who got treatment late never caught up with patients treated early. So it is important that if you have the right tool and the right patient, that you should not delay therapy, even at the level of ET and PV, more so at the level of myelofibrosis. The disease that is more of a window of opportunity is prefibrotic myelofibrosis. These are diseases that look like myelofibrosis, but they're not really meeting all the criteria. We think of them as disease, as a very early form of myelofibrosis. So those patients have become a hot topic for research because it represents a window of opportunity for intervention that could change the outcome for these patients. So now there was a clinical trial that was completed that showed these patients actually do better with interferon. This is that phase 2 study. And now we have a global phase 3 study trying to research whether early intervention with interferon, myelofibrosis will change patients' outcomes. So to summarize, we have made a lot of strides showing that the concept of early intervention is very sound and very doable and actually is effective and potentially even safer than later interventions. And early intervention has many phases, whether you apply more intense therapy early, or you apply the same therapy earlier in the course of the disease, or at a lower risk disease, or even before you get the disease. So all these concepts are applied. So whenever patients present to us, it's always a discussion. I think of MPN therapy as a strategy rather than a decision. There's not one decision, it's a group of decisions that you make sequence to lead to a better future. And it's not about one decision at one point. It is how you sequence your therapy, how you approach your tools, and how to advise patients to make better decisions over time. So thank you, and I hope this was helpful, and I hope this will guide some discussions today.
Wonderful. Thank you so much for that presentation, Dr. Yacoub. That was super informative. Now is the time for us to ask questions to Dr. Yacoub. So if you have any questions, feel free to type them into the chat or use the little reaction button to raise your hand and you can ask that question verbally. I did want to ask you a question before others start to come in. How should a patient go about advocating for themselves if they want therapy? You mentioned that patients and physicians don't always see eye to eye on the best route for therapy or even starting therapy. So, how would you advise patients to go about really advocating for themselves if that is what the route that they want to take?
Well, this is a very important question. It really goes back to many basic concepts. The first one is which I agree with you 100%, is that self-advocacy. Self-advocacy is so important, and patients really in this world have access to tools like your platform, like other platforms, in which they can learn, they can find out ways that are better than that, with care that is different or better than what they're receiving, and seek that care. Sometimes patients come in with material. They tell me, you know what, they're doing this somewhere else. Why don't we talk about it? Or what do you think of this article that was published somewhere in this journal? So I think self advocacy is definitely important and brings the patient's care to a much higher level every time. So I think this is always something we recommend for patients to seek knowledge and attention. And the other really concept is that really in this world and age, the healthcare access is a concern, and there are very few physicians and even fewer specialists. And for patients who are being seen by a non-specialist physician who sees a lot of diseases that are um, unfortunate and much more severe than an NPN, patients with NPN might not get the full attention that they pool. So I think it's very important for every patient to at least have a second opinion during their journey with their cancer, and maybe do that more than once to see if there's any advancements in the field, if there's any ways we do things differently. So to check in with an expert every so many years to see if there's any new knowledge that applies to them, and then whether they get therapy with the expert or with the local doctor. I think this is always, it brings everybody's level higher if
Hmm.
patients seek attention. So yeah, we're definitely many concepts that we all should apply. This applies to this cancer and all other health issues, but it's more so in MPNs because patients with MPNs have been the most savvy, the most informed, the most proactive patients. It's been a pleasure working with them. I've learned a lot from my patients. Um, and also, there's a lot of resources for NPN now. And then patients with NPN live with their cancers for the longest time and decades, the rest of their lives, basically. And and if you're gonna live with this disease for the rest of your life, you need to master everything about it. And that's why for NPN, it's a unique disease in which patients have a lot of role to play.
Yeah, I couldn't have said that any better myself. It is, patients are living with this for a very long time and they do need to become very aware of it. And as you touched on, NPN patients are very savvy. I've worked with the community for the last several months and I've picked up on that. They are very eager to learn, and it's really, as a person working in advocacy, it's really a fun group to work with. So our next question comes from Bruce. He said, on your slide about what patients want versus what doctors want, some percent of patients want to normalize blood counts. Shouldn't that be the target of all interventions, regardless of point in time?
Thank you very much, Bruce. So basically, honestly, that's actually the easiest question because doctors and patients are absolutely in agreement on the solid, evidence-based goals of care. So if you have PV, your goal is to be dramatically under 45%. If you have AT, your goal is to be less than 400. These are never controversial. So really, a lot of this is really solid evidence, and all doctors and all patients will agree on. The slide was mostly about the global wishes and wants of those patients who, after you meet the immediate medical needs, what else is that you want? So again, we're all gonna agree on those well-defined goals of care, which is the objective, measurable lab tests being in the normal range. But then what else? Um, would you be willing to take um, additional toxicity for therapy that is possibly going to benefit you in 5 years, um, even at the cost of more side effects now, even though either way your labs are great, but would you take more or change therapy with the different goals of care? So that's really what that was about. And physicians might want to get those the objective goals met, but then stop there, not to cause side effects. While some patients say, you know what, I'll take the better therapy, even with more side effects now, to improve on other goals that are not just the labs being right. So it really is touching on something bigger than just the simple get the CBC to look right.
Yeah. And then Bruce had a follow-up to that as well. Said MIPS and DIPS tests are again point in time. Should next-gen sequencing be performed at intervals to ascertain disease progression and changes in genetic makeup?
I love this question because actually MIPS and DIPS are dynamic. So that's what the D is in DIPS. So basically, let's say we meet a patient today and their DIPS score shows a score of intermediate or low risk. Then we give them a life expectancy, say, of 7, 8 years. Then I meet the same patient in 5 years and apply the same depths, and they still show intermediate. Then the life expectancy is again 7 to 8 years from that point. So basically, it is dynamic. You every time you apply it, it applies to that moment of time. And if patients don't progress, then their life keeps getting longer and longer and longer because it just did not progress. What usually happens is that your FIP score is intermediate this year. I see you back in 3 years. You probably have other symptoms or labs look different. And then when you apply the same score, then patients score worse on that depth. The MIPS is even more true to that case because same thing, it's also dynamic. So you apply the MIP score this year and you score low risk. That's great. And I see you back in 5 years and you're still low score, then that's also great. Then you're actually your life expectancy got extended by another 5 years because you did not progress in 5 years. But if you patients progress, usually there is a molecular event that happens. So if patients are actually more ill in 5 years, usually the MIPS will reflect that because there's a molecular basis for progression, which is a new mutation. So usually it would reflect in that. So these are really good tools. And the good thing about them is that they're dynamic. And it's great when patients don't progress and stay in the same category on their score all the time. That means their life keeps getting longer and longer. But for patients who progress, those models will capture that too. So they're really useful as a one-time thing and as a multi-point reassessment in that sense. Very good question, Bruce.
He has some real good ones there. Next up, we have one. Sorry, they're moving on me a little bit. From Gary. They say, I was diagnosed with ET in 2016 and myelofibrosis in 2024. Is my myelofibrosis considered primary or secondary?
Okay, thank you, Gary. So obviously, the word secondary myelofibrosis is basically myelofibrosis that has evolved from another MPN. So if you had a clear-cut diagnosis of ET 2016, then the disease itself is changed or transformed into myelofibrosis in 2024. That's a transformed or secondary myelofibrosis. The other big word we use is post-ET myelofibrosis to describe your disease, but it would be called secondary myelofibrosis.
And then Teresa says, I am early pre-myelofibrosis diagnosed in 2023. On ruxolitinib and blood count close to normal, spleen size is reduced. What causes progression and how long can one stay at low risk? Once progression begins, what would the treatment options look like?
All right, so again, cancers progress in a continuous way. So that is not necessarily a stepwise progression. It's more of a continuous process. Progression means many different words, and even the word progression means different things to different people. So in general, myelofibrosis is a progressive disease, um, meaning with time, the spleens get bigger, symptoms get worse, blood counts become more adverse, the bone marrow becomes more scarred, the DNA has more errors, there's more mutations. That's usually what happens over years to decades. Ruxolitinib is a great medication for symptoms and for spleen. And if you control symptoms and spleen long enough, patients actually have slower progression. It does not prevent progression. So it just slows down the pace of progression. And it's definitely an advantage. And sometimes if you just keep slowing it, then you'll never catches up with you, which is actually what happened in many patients in which they had high risk myelofibrosis and they took ruxolitinib, they got better and lived longer and just lived a natural life and died of old age or other health issues. which means basically myelofibrosis was not the reason for their life to end, which means ruxolitinib did prolong their lives. So nothing wrong with a drug that slows down progression, but it does not prevent progression. And progression has uh, um, many faces. And actually, the stem of your question can answer some of that because you're obviously thinking about it. So worsening symptoms, worsening spleen, worsening blood counts is all adverse and is all progression. And that is not something that happens suddenly. It's always something that happened in a smoldering way. And so far, ruxolitinib is a tool to slow that down.
All right. Next, we have a question coming in from Sandy. Is there a role for hydroxyurea treatment of intermediate risk primary myelofibrosis?
Honestly, not in this time and age, because we have four different JAK inhibitors. All of them have roles in myelofibrosis. All of them provide certain benefits. There is really very little role in hydroxyurea in myelofibrosis altogether. Now, some patients with myelofibrosis are very early and they're very proliferative and they're making too many platelets, too many red cells, and clotting and bleeding. Hydroxyurea might provide a very good bridge to control the blood counts. Um, but it's often not the best therapy to stay on long term. And now that we have many more agents that are a lot more effective, I think the role of hydroxyurea is shrinking significantly.
Next, we have a question coming from Helga. Are there any clinical trials known who study patients who don't start any JAK medication yet, so that they can better decide on the best strategy to approach the disease?
Well, thank you very much. So, honestly, at this point, we've had a decade and a half of JAK inhibitors. And for JAK inhibitors, patient myelofibrosis did extremely poorly. It's a very unfortunate era where we really had no tools for patients. Then came JAK inhibitors, and patients are thriving great and living longer and feeling better, and really the whole revolutionized the whole field. So going forward, for everybody in which a JAK inhibitor is indicated, it's really almost unconscionable that we would offer them therapy instead of JAK inhibitors. So we've been really finding a big ethical and scientific line to cross when patients who have myelofibrosis who benefit from JAK inhibitor are not given JAK inhibitor. And one evidence is what I showed you earlier, in which the comfort study patients were both got Jakafi, but first were randomized. One got ruxolitinib and one got placebo. They crossed over in 9 months. So that delay of ruxolitinib was detrimental. Patients lived shorter because they did not get ruxolitinib on time. So really, with all this information, it is really beyond our medical conception that we would not offer patients the right therapy that is associated with activity and benefit and survival as soon as the patient have indications. Now, there are some patients with myelofibrosis where JAK inhibitors are not approved yet. For example, the lower risk myelofibrosis. So I would expand a little bit on your question. For patients who have indications for JAK inhibitors like intermediate to high risk, they should be getting JAK inhibitors as a standard therapy. But for patients who are early myelofibrosis, patients where Jakafi was never studied, JAK inhibitors, for early myelofibrosis, for low risk myelofibrosis, for prefibrotic myelofibrosis, for those patients, we are doing studies. We're giving interferon without a JAK inhibitor in the equation. So yes, we are doing that in patients in which a JAK inhibitor is not. But for any patient in which a JAK inhibitor is approved, I find it hard to not give them the standard of care therapy that is already of proven benefit.
And then she has a follow-up question with a little bit of context added here. So my mom has JAK2 mutation, test positive in peripheral blood, VAF 20%. Bone marrow examination confirmed primary myelofibrosis in the prefibrotic stage. Currently taking medication, aspirin protect 100 milligrams in the evening, amusia level 18.9%, ultrasound negative, spleen no larger than 33 by 94 millimeter, THR 1143. Her spleen is not larger, but her THR is increased from 600 plus in 2019 to 1143 in 2024. Are there any treatment suggestions for such a case to help reduce THR while her spleen is still a normal size?
I'm not familiar with the term THR. Is that the platelet count? Um,
I'm not sure. Helga, if you're listening, can you um she said thrombocyte.
so probably the platelet count, thrombocytes. Okay. So basically, the platelet counts. Actually, this is the classic example I was mentioning a second ago. So basically, those studies, the new generation for lower risk of prefibrotic myelofibrosis with interferon, are targeting patients exactly in that phenotype. So your mother has myelofibrosis. She does not have a JAK inhibitor that is approved for early or prefibrotic myelofibrosis. So there is nearly no standard, clear cut, unquestionable standard of care for your mother. And she has high platelet counts, and she would want or benefit um, from
We lost your audio again.
how about now? Because I was
A
getting a
little.
weird message.
There you go.
Yeah, yeah. Something wanted to switch my language to Spanish for someone.
Weird.
Yeah. So the clinical trial we discussed was exactly for patients like your mother's, patients who don't have JAK inhibitor approved or needed, and they have abnormal blood numbers and they need therapy. So what do we do? And now, yes, we do have a clinical trial for that, specifically dedicated for patients like your mother. And the goal, so clinical trials are an experiment. We don't know the results of them, which means you have an intervention that you think might help people, but you can't say it does help people until you run the study. And the study will randomize people to a treatment or a different treatment and to see which treatment is better. So that's what trials are. That's what research is. And there is this research going on to see if one therapy would help patients more than nothing, which is the standard of care. So that's actually a great example where we're trying to find more options to help more patients that don't have actual tools to help them now.
And then following up on that one, since you did mention this study, is that trial still open for enrollment? And how would a person go about
Yeah,
enrolling in a trial?
this is a global clinical trial that is going to open in multiple sites in the US and the world. So I don't think it's activated yet, but it will have be a large study, and it's going to be open in many, many places in the country.
Awesome. So not open yet, but will be enrolling fairly soon. All right.
Right. And
And
then the
then,
next question by Bruce. Yes, Bruce. So that is actually also another aspect of myelofibrosis we don't talk about much, which is in myelofibrosis and all MPNs are cancers that are chronic, and the way they evolve includes multiple aspects of the health, including the autoimmune system and inflammation. So there are therapeutics and interventional trials in which we're trying to treat myelofibrosis by changing some aspects of the immune system or the chemical signaling or diet or yoga. So there are actually sub concepts, not necessarily full blown, but there are dietary interventions, the trials. They're, they're still in feasibility phase. Basically, can it be done or not? But basically, patients are randomized to Mediterranean diet or no intervention, and see how they do on the long run. There are trials randomizing the oxidant versus nothing or no intervention. So there are studies utilizing yoga versus no yoga. So basically, there are concepts like that that are underway, and it really is patients who live a long life with one disease. I think a lot of those common sense interventions are absolutely of low risk and high yield, whether you get on the study or through your own efforts. Eating healthy, exercising, using antioxidants. Again, all this can't be bad for you, right? So it must be good for you, good for your health, and if it helps the cancer, that's wonderful. So yeah, these are still going on and in concepts. Now, some of the pharmacological interventions like that, there's also studies like that. There are drugs that are anti-inflammatory or anti-signaling that affect certain proteins like TGF-beta or interleukin-6, or basically not cancer therapy. They're like chemical modulation of the body, changing inflammation signature. So some of those things are also going on, and we actually have some of them active at our institution. And we're just exploring whether this would be of benefit or not. So yes, there's a lot going on that aspect.
Yeah. Um, Touching on the diet one in particular, I did want to give a shout out to a previous webinar that I did earlier this month with Dr. Angela Fleischman from University of California, Irvine. She is also an MPN specialist, and I had her come on and do a webinar where she discussed looking at how diet affects MPNs. So if you are curious about that topic, I highly recommend you watch that recording. It can be found on our website, as all of our events are recorded so that you can find them all. So the one with Dr. Angela Fleischman from earlier in October is a really good resource for that one.
And I highly
And then,
recommend. Yeah, Angela does a good job with. She actually has been a leader in that discipline of medicine. So yes, I highly recommend that as well.
yeah, all right. Looks like we are at the end of our questions from the audience. Actually, we had one more come in, so this will be our last one before we wrap up. For let's see, it
Yeah,
says
so for
PMF. There you go.
can you start? Yeah, so for myelofibrosis, we advise you start two drugs or a single JAK inhibitor. So that is the million-dollar question. That's why we're doing so many clinical trials. We still think that we will find a combination that is better than single agent JAK inhibitor. So we've had negative studies, but they were negative for not the right reason. Still doing more studies now. There's still always studies trying to investigate if you interfere early, two drugs, can you get better bang, better response, response that is deeper, the higher quality, maybe even less side effects, maybe a response that will last a lot longer. So we're still investigating that, and there's always trials combinations still.
Awesome.
Yeah, and that might be
All
the
right.
closing message is that if you have access to a trial, please make it a priority to enroll. Because that's the only way we come up with new options.
Yeah, clinical trials really do help drive the future. All right. So thank you again, Dr. Yacoub. That was a wonderful presentation, and you did such a great job fielding all those questions. So I really do appreciate it. And let's see. Before we go, I want to highlight how to connect your records in CureHub. After creating a HealthTree CureHub account, you're able to electronically connect your health records from any facility into your profile. Once your records are connected, you can now view a comprehensive overview of your medical history, including your diagnosis, genetics, lab results, treatments, all within a single user-friendly interface. Only takes a few moments to create the connection and to start taking control of your diagnosis. On the screen, I have the link to sign up for the HealthTree Care Hub, along with the email address for amazing patient navigators who are able to help you create an account and connect your records. I'll also include some information about how to enroll in Cure Hub in our follow-up email, so be on the lookout for that. As you leave today, I would again urge you to take that quick survey. It really does help us identify topics that the community is interested in. We do have a upcoming event in about 2 weeks from now. This will be current treatment options and things to consider for myelofibrosis patients with Dr. Anand Patel. And then we're actively working to plan even more. So filling out that survey will help us identify what you're really interested in. So thank you for taking the time to join us today and helping us grow this community. I want to give a special thank you again to Dr. Yacoub. That was truly excellent. And please don't hesitate to reach out to me if you have any questions about HealthTree, any of our programs, or if there's anything that I can do for you. I appreciate you all, and I hope that you have a great rest of your day. And I
Thank
hope
you
to see
guys
you at
and have
another
a good
webinar
evening.
soon. So thank you.